fish oils, and vitamin E. I mean, sometimes you have a combination because some people have such bad lipids. You have them on 3 or 4 different things, and they're going like, eh. Some things have less side effects than others. Statins are pretty much used for people not having a problem. The issue is, of course, is that was one of the drugs they wanted to put over the counter. I said, you know how many dead people you're going to have doing stuff like that? Because you know how it is. We take one that's great, so 2 will help my cholesterol even better. People not realizing that it's a drug that requires, you know, therapy, that you have to actually look and say, I'm monitoring what you're doing. And most people won't do that. They're just going to take the medicine.
But if you usually don't have like cholesterol issues and you're just going in for like prophylactic, then the vitamin E and fish oil should.
Yeah, if you don't have cholesterol, the one thing that has changed over the years, I will tell you, because you know we used to say that if a patient's cholesterol was 200, that's when they got the drug. Then it changed for, you still do that. So if your cholesterol is over 2, you may see a doctor that gives you a trial, but I'm telling you, most people give you drugs now. But the thing is that we didn't treat a whole lot of people. If you were like 215, 230, we didn't worry. Your HDL was okay or a little bit low, we didn't worry. Now the big focus is not just looking at cholesterol, but LDLs. That's where the big focus is now because they know that that's the one that affects the coronaries more. So that there was a time when the only patients you treated with an LDL over 100 was a diabetic. Now it's everybody. So that's the change in what people are seeing and why we put people on sooner than later. Because if you add those things together, as far as the LDL over 100, hypertension, all that, that's what accelerates that whole process of atherosclerosis. So now you'll see people, even if you have a normal cholesterol, because like mine is, but my LDL is high. So that's why I take a statin drug. But I take the lowest dose because I'm one of those, I don't know what it is about my retarded self. Because I told y'all when I take pain medicine, I'm like, ow. It's the same thing with cholesterol drugs. I take a cholesterol drug, I had got my cholesterol was so low, the doctor said you got to come off meds. My LDL went down. Within a month, I went from my highest was 126, which would have been okay before, but now they don't. Plus, I have hypertension, so any risk factor, they're going to treat you for it. But they put me on drug. I went from 126 to 89 in a month. And so I was like, okay. So I'm still taking my medication like I'm supposed to, going for my 3-month checkup to get my liver function test, everything fine. My cholesterol was down to 94. She said that's too low. So I had to go off drug for a while. So I have holidays from my cholesterol meds because they work so well, kind of thing. But I only take 5 milligrams a day. So some people take a lot more. But you know, I was on 10, and I cut down to 5, and even with 5, I had to come off meds 4 times with my retarded.
Which one?
Crystal. Yeah. Now the reason I take that one is because I told y'all, if I got to risk my liver, that's the one cholesterol drug that shows promise in treating Alzheimer's. Because Alzheimer's is a plaque formation in the brain. So I said, if I got to risk my liver, I'll try not to be really retarded and take Crestor. So I mean, if I had to take it, I mean, I do have to take one because the doctor even asked me, said, which one you want? That's what he tells me. Which drug do you want? I said, well, since I'm already retarded, but I don't really want to be in real life, I'll take Crestor. But that's, for me, it's 5 milligrams does it. And there's different dosages that patients have. But that's the thing, you have to make sure that your doctor is periodically testing your liver function. And then if you have any muscle pain and weakness, report it. Because what ends up happening, because you know how it is, you guys work all the time. You know, or say you were moving stuff for the hurricane. If you have muscle pain and weakness, you just put it off to, I was moving stuff at my house, I moved the patient. That's how we would look at it. Then you wake up one day and look in the mirror and you're jaundiced. Because that's the kind of thing that happens, because it will kill off your liver. And you'll see people come in yellow sometimes, and you're thinking, I told you to come and tell me when you had muscle pain and weakness. Well, yeah, I thought it was stuff. But then when I turned yellow, I thought I need to come in. Duh. When you're jaundiced, we may not be able to reverse that whole process, but people do stuff like that. It's craziness, but that's the way it works. But that's the goal right now is to treat anybody who has an LDL over, they want everybody under 100, no matter if you're diabetic, hypertensive, or even if you have no health issues other than your cholesterol is high. That's what doctors are doing now as far as treating their patients. So that's what you have to, but that part, when you listen to the commercial on TV, he's real quiet, almost getting that across, and you're like, geez, what are you talking about? I missed that whole thing. And it's bad, but that's the worst case scenario. But rhabdomyolysis is what you're worried about when the patient complains of muscle pain and weakness. Okay. So when, the other part about what we talked about CRP, your liver function test that you're going to be doing for your cholesterol, all that kind of stuff that you're doing with your patient. The other thing that you might see is, especially because as you get older, you know, that plaque formation is happening, we usually see coronary artery disease happen between the 5th and 6th decade of life, is when you see people being symptomatic. Of course, you know, we can have people that present with at any age, because family history trumps all the stuff that we know about science. Early, if you see a family that has, especially with guys, if you have people that have coronary events in their 40s, it's a consistent thing, 30s and 40s, it's going to be a risk factor for every guy in that family, 30 and 40 years old. With women, it tends to be about 50, because most women don't present with coronary symptoms until their 60s. So when you have women who are having cardiac events in their 50s, that's considered high risk. Not that we don't have them, but that's the issue that you look for. So, and the bad part about it is, especially when you talk about coronary artery disease, you think about this plaque formation happening there, but your body tries to compensate for that. Your body is a miraculous thing because it tries to save you all the time. And so what happens when you're talking about the development of coronary artery disease, if I have a place that is blocked, I'm going to create a pathway around it. That's what collaterals are. Okay? Collaterals don't start happening until your late 50s, early 60s. Okay? That's why people who are older do better with a heart attack than young people. Because think about it. If you have an area that's blocked in the heart, because say these are the vessels that are here, the main ones. Okay, so you have the RCA, which is the right coronary artery, the left main. They're talking about the coronary arteries. Those are the bigger ones. Then they branch off into smaller ones. Okay, so say I had a blockage here. So I start seeing plaque formation, and patients sometimes are not symptomatic until they get a 70% blockage. Now, nobody knows that 70% until they go in and do a cardiac cath, but the patient may not be symptomatic until they get a 70% occlusion. It just depends on the patient. Okay, so you got a blockage here. What happens when you get collaterals is that you see an impairment happening. So you say, what? I need to create a blood vessel around that. So when you see older people, they have a lot of those. Collaterals are things that are letting blood flow around it. So your body, it's a totally pathologic process. But those little new creation of tissue or vessels are what's going to save heart tissue. So in your head, think about, you know, when the beaver builds a dam, most of the water stays back, but there's always a trickle that goes by. Think about that as the blood supply and the collateral. Even though I have a blockage there, I also have an area or a spot where I'm getting blood around there, so tissue is getting nourished. That's why older people live after a heart attack. If you have no collaterals and you have a big clot there and it cuts off blood supply, tissue is going to die. That's why 30-year-olds drop dead from a heart attack. That's why 40-year-olds drop dead from a heart attack, because they don't have this. So that's why older people do better when you're talking about having a heart attack, as far as tissue salvaging kind of thing. Yeah?
Did you say age at 65 years old?
No, late 60s. Yeah, because at late 50s, well, you can have collaterals. Usually happen late 50s, right before 60, and they continue on. But there's not happening in somebody 30 years old. So that's part of the reason why when you see young guys have a heart attack or young women have a heart attack, that they die, and it's because of the collateral situation. So that's something that's actually a totally pathologic process, but it's something that your body's doing in essence to say, I need to get blood supply to this other place. Okay, so those are things that are happening because of atherosclerosis. I have that plaque formation there. So when we have patients who have this going on, that's what ends up causing decreased perfusion. Ischemia is something that you see in those patients. And then, of course, if you continue that ischemia for a long time, you're going to have tissue death. So that's why there's a continuum of things when you talk about acute coronary syndromes, unstable angina, all the way over to acute MI. Now, we talked about angina before, so we know that there's when a patient has unstable angina, or angina is considered chest pain. So decreased perfusion, that's what's happening with your patient. The very first time the patient is admitted to the hospital with chest pain, you're either going to get these two diagnoses. That's why I kind of put those together. Very first time they come in the hospital, they're going to be admitted with unstable angina or acute coronary syndrome. Because doctors, we don't know why it's happening to the patient. They never had it before. There's no history that says this person has a problem. Okay. Now the thing about it, the reason I say it, because that's something that you'll see written on a chart. You may have a person who has a known history of coronary artery disease that now has a change in their angina. Because remember, stable angina follows a pattern, meaning that if the person walks up a flight of stairs that has 8 steps, they get chest pain. And every time they get to the 8th step, I grab my chest. Or if you got somebody sweeping the kitchen floor and I get over by the refrigerator every time I have chest pain, that's stable angina. There's a pattern that is predictable about when the patient develops chest pain. So a patient with known coronary artery disease, because you've had the diagnosis now, I know that, it's always the same. Known coronary artery disease that now changes is also called unstable angina. Okay, because now it takes me 4 steps and I have chest pain. Now I can't even get past the stove and I'm having chest pain. So there's a difference in the pattern. But when you do that in known coronary artery disease, because you had the diagnosis before, you go from stable angina to unstable angina. Okay. When you have a patient who never has any history of anything, ever, at all, kind of thing, and comes in and has a heart attack, that's also called acute coronary syndrome. So that's why sometimes it gets lost in the what's happening with the patient. But out of all of those things, there's tissue ischemia. That's what you got to think about that's happening with your patient. But no history ever at all, you've been healthy all your life, and all of a sudden you have a heart attack, that's also called acute coronary syndrome. But it's positive for MI, that's the thing that they're looking at. So just know you may see different things that are very close in how you describe the patient. Most of them you have to look at is what is my history, what symptoms does the patient have, all that kind of stuff. Timing, those kind of things, kind of give it away about what's happening. So first we're going to talk about unstable angina. So you're going to think about it in the context of a patient who has known cardiac disease. So I know they have coronary artery disease because they've been diagnosed before. Okay. So now there's a change in the pattern to their chest pain. And this is the part that kind of you worry about with a patient who has known coronary artery disease who now has unstable angina, is that there's something happening with their plaque. I need to intervene. That's why they always bring them in the hospital. The patient may go for a cardiac cath, that kind of thing, because I know that that plaque is becoming unstable. Because now it's changing their pain. They may have more pain, they may have it more frequently, they may even start having pain at rest, not doing anything, and they start having chest pain. Because when we think about it, it's usually associated with some type of activity because there's a mismatch between depliance demand. Because I can't get past it, the decreased lumen, I need more blood because I'm up doing some type of activity. That's why activity usually brings on chest pain. If you eat a big meal, like we do on Thanksgiving and other occasions, or like you might have done Sunday watching the game. Now I know Cornelius is not eating wings anymore, so I don't know. All right, but you're eating a big meal, your blood goes to your gut, after you eat a big meal. That's why you always want to sleep, because there's no blood up here. It's all in the gut at this point. So when that happens, that's a lot of times patients will tell you, I start having chest pain after I have a really big meal. Because the blood supply is not here anymore. It's at the gut. Okay, so that's why you tell people, yeah, eat a meal, but don't go crazy if you got coronary artery disease. I know it sounds like simple stuff, but that can make a difference as far as your patient goes. Okay? So when I have unstable angina, I have a change in that pattern. No longer do I have the predictability that's going on. Now the thing that we see, or what you want to make sure that patient understands is, if they took a nitro and their symptoms don't go away, because a lot of times when a person sits down, it gets better, right? Because I'm resting, the myocardial oxygen demand is decreased, so this person doesn't need anything, I can have them sit down, they're okay. Take one nitro, symptoms aside, I still need to call my doctor and let them know that there's a change I noticed. The time that person puts the second nitro under their tongue, they need to be calling EMS. We used to tell people do 3 nitros. No longer do we do that. It's the second nitroglycerin means I'm calling EMS to get to a hospital or something like that, because the sooner I do an intervention, the better for the patient. So, when you see a patient who has ST or has unstable angina, they have some changes that indicate ischemia on the EKG that you might see like on a test. When you have patients who have ischemia, some of the changes that you might see on an EKG strip are ST depression, so the ST segment goes below the baseline, or they may have T-wave inversion, so the T-wave is turned upside down. So instead of the T-wave being here, you're going to have a T-wave like that. And then when you're talking about ST depression, you're talking about ST segment going below the baseline. And when you talk about baseline, if you look at an EKG strip, everything looks like it's going on an imaginary line. But what happens is you're going to have something that you can see that makes it a little bit different. So T-wave inversion means it turns over. And then when you have ST depression, the ST segment goes below the baseline. Those are things that indicate ischemia. This is my target. I want to turn this around in my patient. Okay, so putting them on O2, giving nitrates, because nitroglycerin is a vasodilator that's going to increase the diameter of the vessel so they can get blood flow. Oxygen, because that's the issue that they have. All right. I'm also going to do an EKG because that's going to give me a picture of what's happening with my patient. Now, if their blood pressure is really low, morphine would be what I give first. Even though nitrates will help, nitrates vasodilate, but they drop your blood pressure. So if BP is really low, I might opt to give 2 milligrams of morphine. You don't give a lot, but you're going to give the patient something for pain. Monitor them, see if they're diaphoretic, see if there's other symptoms going on. They will still work them up as if they're having a heart attack. So that's one of the things. You come to the ER, you say, my pain is changing. They're going to do that because if that plaque is changing, it may have sheared off, or you might now have a 90% blockage. So those are things that we have to address in the patient. And one of those things when you think about coronaries, you know, when patients, or you listen to a report, and this is the reason why I want you guys to go to the cath lab with a patient. When they talk about that whole process, doctor explains to you, patient came in, I mean, they give you the history about what's happening with the patient. They do the procedure, you're actually able to see the area of blockage. For you, sometimes the doctors want you up there, sometimes they'll have you watching a monitor. But you can see